Ensuring patients with opioid dependence get the best outcomes possible can take teamwork.
So the role of an AOD counsellor, in particular with opioid dependence, is to meet the client where they are. So it's a very person-centred approach. It is trauma-informed. We're well aware that people may have had a wide variety of different experience and comorbidities of different mental health issues. We know that counselling and ongoing counselling in particular has a strong correlation with reduction in all different kinds of negative symptoms. At CoHealth, we only use evidence-based approaches, and the primary one is cognitive behavioural therapy, which is probably quite a widely known therapeutic approach. But really what we're looking at doing is bringing into awareness thoughts, feelings, and how they result in actions for people. So that's getting awareness of why you may act in a particular kind of way, and then having a look at what are the new strategies that you may be able to develop to do things differently in your life. Specific approaches with that will be motivational interviewing, so we're looking at enhancing the change process into recovery. We're also looking at lapse and relapse prevention, strategies around managing cravings, for example. And also another therapy we use is acceptance and commitment therapy, another evidence-based approach. Its most effective way to access it is by using Direct Line, statewide catchment-based service, 10 to 15 minute interview process. It opens up the assessments for counselling, detox, rehabilitation, non-residential nursing services, a wide range of support.
So if you've got someone that you've seen that's had pain for 3 months and it's not improving, it would be really good to refer to Allied Health. Or if it's someone that's had a recent onset of pain but they've got lots of issues psychosocially, refer to Allied Health, because I think if we can intervene early, it stops the cycle. A client came and saw me, I would do an assessment hearing about what they feel and think about the pain, how it's affecting their life. An example around the body is people have a lot of fear about what the pain means, what's causing it. So we spend a lot of time on education around what that means, that the injury is often or generally healed, and that it's the fact that the nervous system is overactive, resulting in the ongoing pain experience. And then people's anxiety and worry, lack of sleep, all of those things are also increasing that pain experience. We would do a physical assessment as well, look at how people can move, look at their strength, look at what they're able to do functionally, and then work with the client around what they want to achieve. We might prescribe an exercise program that they do at home or they do with us, and generally slowly build up. One option is community health services, so they're generally state-funded services, or you can access private practitioners through the team care arrangements. And then there's also tertiary pain clinics. So in our current context, the closest ones here are Royal Melbourne Hospital and Sunshine Hospital, but there's often large waiting lists.
GPs have a clear role in prescribing appropriately. It goes right from the start when we first start treating people with pain, that we need to be careful about who we give medication to, what medication we give to them, how much medication we give to them, and for how long we treat them with opiate-based medications. It means doing accurate and detailed assessments of people prior to treating people, and really making sure that they're functionally improving. And if they're not, then this medication is not right for them. There's no evidence that treating people with prescription opiates for non-cancer pain is beneficial for anything longer than 12 weeks. It's probably not even beneficial that long, actually. GPs will often say, well, look, I didn't start people on this medication, they came to me from hospital on opiates. So the GP has an important role there to not just continue to prescribe opiates forever. When they first come to you, you need to set the boundaries and start to say, look, this medication may have been helpful while you're in hospital. Maybe I'll continue to prescribe it over the next week or so, but then we'll be reducing it quite dramatically, that we won't be prescribing ongoing. We'll find other ways for you to manage your pain, which may involve physiotherapy and movement and massage and acupuncture and a range of other therapies. If somebody's been on opiates for a long time, it's important to reduce their dose slowly, actually. But if it's found that people aren't able to tolerate that, even reducing slowly, that the other therapies aren't helping, that they're showing symptoms of opiate withdrawal, for example, then switching them to a longer-acting medication may be more beneficial. For people who are looking to prescribe these treatments, there is more support than there is for the prescription of any other treatment that we do. The DACUS, the Drug and Alcohol Clinical Advisory Service, that you can call anytime to get support from a specialist. Pharmacotherapy networks often offering support with an addiction medicine specialist.
So certain people who are particularly complex, like pregnant women, have different needs. People with complex mental health, people with behavioural issues, people with chronic drug dependencies are better treated by specialist services. But that's a small percentage. I'd like any doctors who are watching this to come to one of our trainings at the College of GPs. Most people find them enjoyable and informative, and they leave with a different understanding of what dependency is about.
Pharmacists need to be comfortable having conversations with people around escalation in dose that shows that, one, somebody's pain might not be adequately controlled, or that their use of medication is actually no longer about pain and now might be due to either tolerance or dependence. We'll have people who are on a relatively high dose of opioids for their pain. People should know about naloxone and should have access to it. Family members can now buy it over the counter as well. It's a bit more expensive, but it is a potentially life-saving medication to have on hand. I guess the biggest concern is around either prescribers or pharmacists that are practicing in a way that is unsafe for patients. Pharmacists do need to have confidence in talking to other health professionals about an issue if they see it. But they also need to be prepared with that conversation. Generally speaking, if I find somebody who can identify a problem but doesn't want to address it, the best way to think about it is if you were the patient, or if your family member was the patient, what would you want them to do? When we're talking about the program of harm minimisation and opioid replacement therapy, one of the roles of the pharmacist should be to coordinate with the prescribing doctors so that when people are due for a new appointment for their prescription, there's been a conversation about anything that might be an issue.